retired naval commander, I could say attention on deck. When I used to say it in the Navy, it was much more forceful than that. And it did get people's attention. But good evening. It's my pleasure to welcome all of you here tonight. Good evening, Dr. Brawner, Dr. Sipple, faculty, students, and staff who are members of our Moravian College community, and our guests who are friends of nursing and friends of Moravian College. Many thanks to our own student, Trevor Glanville, for providing such lovely music to us. Our students are so multi-talented, and I don't want it to go to Trevor's head, but he's a very talented young man. And thank you very much, Trevor. At this time, I'd like to introduce to you the president of Moravian College, Dr. Christopher Tomford, who would like to share some words with us.
Good evening, everyone, and welcome to Moravian College, Moravian Theological Seminary. I'll be in like a racing posture. No. See, I think we're fine. I was walking down to Foy Hall from my office up in Colonial Hall, and I was thinking, what should I say to this group of people? I was handed a bulletin, and I think everything that needs to be said is on the front cover. We need to hear a lecture, of course. But let me underscore some of these things. St. Luke's School of Nursing at Moravian College. What a wonderful partnership we share. And as president of the college, I just want to say we are 100% in favor of this partnership and want to do everything possible to let it flourish. This is in partnerships, at least the ones I've entered into, two strong bodies come together to make each other stronger. And I believe there's a great synergy here. And thanks be to God for the partnership we share. Janet Sipple. Now here's a dynamic force. We're not really here to talk about Janet, but I can't help myself. There's an itinerary to her life that has touched many bases. The one that I celebrate is this point in time, your leadership here and your capacity to bring this nursing school into being. And she's a Tar Heel fan. I didn't play for the Tar Heels of North Carolina, but I've always admired them. So Janet, we are here to honor you and give thanks for your leadership. Let's skip one piece and look at the three titles here. Sustainable change. Is that possible? Who heard of such a thing? Who wants to change? And how would we ever make it sustainable as opposed to cacophonous or tragic or tumultuous or overwhelming? So thank you for this hopeful title, Sustainable Change. We can change, we can become new, and it can be sustained. Health Equity. What a wonderful title in a time of society when there are so many inequities, rich and poor, black and white, gay and straight, tall and short, bald and hairy. Equity. Who's being left out, and how do we welcome all, include all, into the centers of well-being, privilege, security? As a white man, I've occupied the center position much of my life, but it's been my vocation to welcome people in who had otherwise been held off with the stiff arm of indifference. Active community engagement. No one will accomplish any of what we're about to hear tonight by him or herself. The Moravian community will have to become fully engaged in this. The Lehigh Valley community will have to be fully engaged. Nurses, doctors, lay people, we will all have to be fully engaged. and Dr. Bridgette Brawner. Thank you for coming, honoring us with your presence. Sustainable change, health equity, community engagement. I have to learn about all three, and I'm looking forward to learning from you. Thank you for coming.
I have to readjust. So thank you for sharing those words with us, President Tom Ford. It is now my pleasure to share with you the story of the Sipple Lectureship. The Janet A. Sipple Lecture Series was established in the spring of 2006 to honor Dr. Sipple's professional leadership and commitment to collegiate nursing education upon her stepping down as founding chairperson of the St. Luke's School of Nursing at Moravian College. Indeed, Dr. Sipple has enjoyed a long and distinguished career in academia. As founding dean of the Barnes College School of Nursing in St. Louis, Missouri, from 1991 to 1994, and as the chairperson of the Division of Nursing at Lander University in Greenwood, South Carolina, from 1976 to 1991. This lecture series was established by Dr. Sipple's good friends and colleagues, many of whom are with us this evening, including Mrs. Betsy and her husband, Mr. Randall Leyland, and Miss Joan Lardner-Paul, in consultation with members of the nursing faculty at Moravian College to, quote, provide for an annual lecture in the area of international healthcare, world community service, leadership, or public health, open to all students and members of the greater Lehigh Valley community. The theme of this lectureship series is certainly fitting for a woman who devoted most of her professional life to leading baccalaureate nursing education programs and to promoting international healthcare initiatives. Janet A. Sipple founded the Australian American Nurses Exchange Program in 1991, and she continues to serve as a professor at the University of Southern Queensland in Toowoomba, Queensland, Australia, where she was honored with a Doctor of the University honoris causa in 2003. Another accomplishment that Dr. Sipple is so pleased to share with everyone is that her own daughter, Elspeth, who is here with us this evening, is also a registered nurse. In addition to all of these noteworthy accomplishments, Dr. Sipple spearheaded the development of international healthcare courses offered for nursing majors at Moravian College. These educational offerings have sent numerous students and faculty to developed yet distant parts of the globe that include Queensland, Australia, and to underdeveloped or challenged parts of the globe, such as Gracias a Dios, Honduras. In the words of our most distinguished colleague and Moravian College alumna, Dr. Margaret McClure, Janet Sipple had the vision, talent, fortitude, and magnetism to develop a baccalaureate nursing program at Moravian College that hit every benchmark in its short history. She is an extraordinary teacher and leader who developed international nursing exchange programs, particularly the opportunity for students to provide aid to the rural Moravian community of Aguas, Honduras. It is truly fitting that we honor this fine educator, innovator, mentor, and friend through offering this lectureship series. And now it is my distinct pleasure to introduce you to Dr. Jennifer Specht, who will introduce tonight's distinguished lecturer.
Thank you, Dr. Cheever. Dr. Bridgette M. Brawner is an assistant professor of nursing at the University of Pennsylvania School of Nursing. She is a member of the school's Center for Health Equity Research and the Center for Global Women's Health. For the past 7 years, she has been involved in several local and international research projects focused on improving health and reducing risk behaviors. Through a health equity lens, Dr. Brawner's program of research focuses on multi-level, multi-method, biobehavioral approaches to sexual health promotion in disenfranchised populations. There are 4 interconnected arms. Number 1, elucidate salient individual-level factors that protect against or increase risk for adverse sexual health outcomes, such as HIV and other sexually transmitted infections. Number 2, explore the social and structural contexts in which relationships develop and sexual behaviors occur. Number 3, mobilize communities and integrate findings to identify modifiable factors. And number 4, develop, test, and disseminate multi-level, comprehensive, evidence-based health promotion and disease prevention models. Dr. Brawner has a passion for urban women's mental and physical health. She believes in upfront, active community engagement coupled with innovative research methodologies can facilitate sustainable change in a myriad of geosocial settings. Dr. Brawner earned her baccalaureate degree at Villanova University. Woo! I'm a fellow Villanova alum, so. Her master's and doctoral degrees from the University of Pennsylvania School of Nursing, and she has received numerous awards and honors in recognition of her distinguished research, teaching, and community service. It is my distinct honor and personal pleasure to introduce you to Dr. Bridgette Brawner.
Do you need me to turn this one off here? Sit down here. Okay. Can you hear me okay? Good evening, everyone. It truly is an honor to be here with you this evening. I am humbled. Anyone who's heard me speak before probably gets sick of me saying how humbled and honored I am to be somewhere, but I truly am grateful for all that God has done in my life, and especially to be here on this evening in honor of such a visionary and amazing woman makes me feel that much more. So can we just again celebrate Dr. Sipple for her wonderful leadership? Thank you. And I apologize to Dr. Speck for the tongue twister bio. I did it on purpose so that when she came up, the words would be stumbled. So tonight, I'm very interactive by nature. So as we go along, I'll ask questions and they aren't rhetorical. I want to hear your thoughts and your feedback as we move along. But first, I also want to introduce my family who's here with me. My mom, Charlene, is here. My son, William, is here, and you'll behave for mommy, right? Yes, very good. And my cousin Tina is here as well, so I'm grateful that they've traveled to be with us. So as we start, I just want to kind of orient you to what we'll be talking about for the next 45 minutes. After your president spoke, I said, well, maybe I don't need to lecture because he pretty much covered everything that we'll be speaking about. But first, I just want to review the implications of health inequities. What does that mean for our society? What does that mean for the world? And how then are we as nurses responsible to do something about that? Next, we'll discuss the importance of actively engaging the community. And as we continue to talk, I'll use that word active intentionally and later unpack why I harp on the word active. And then look at some strategies to promote sustainable change. So the social determinants of health, we hear it thrown out there or people talk about it, but do we really know what they are and what that means? Basically, they are the conditions in which people live, grow, and work. So it's either their place of residence, the type of job they have, the areas where they have social connections with other individuals. In this framework, we then acknowledge that the space that people interact in, whether it's a lived environment or a social environment, influences their health potential. Not only the outcomes that we see in their health, but also their potential to reach a certain level of health status. So if you can see from the images here, someone who has the opportunity to travel to the moon may have a very different lived experience than someone where this is what they passed every day, sort of graffiti, dilapidated living environments, compared to someone else who maybe lives next to plants and factories and might have environmental exposure. So we just want to be cognizant of how, again, these interfaces for where people live, where they grow, where they work, where they're born, will ultimately impact their health. And if we wanted to be the best healthcare providers in the world and get all the advanced degrees that were available to us, anything that we tried to do would fail if we did not acknowledge these root causes. And I had an opportunity to have lunch with some of your faculty, and we kind of talked about some of the things that go on that will play not only into someone's health, but also their ability to learn or how they engage in a classroom. So we have to make sure that we get down all the way to the root cause of the problems that we're seeing. So I have an example for you. Braveman has an article that talks about this notion of the cause of the causes. So if we think about something like high childhood mortality from diarrhea, what do you think might be some causes of that? Bad water, parasites, exactly. I heard another one. Transportation, right. So let's say you get in this community, you think it's in the water, so you go, you get a water sample, it comes back that there are pathogens in the water supply. So you go, you clean up the water, you find ways to make the water potable, and then you leave and you come back home. And then you hear again that they're having high childhood mortality from diarrhea. What might you think of from there? Rotavirus, nutrition. And put the social determinants of health cap on too. Lack of education, routine education. How about an absence of policies and standards to ensure water safety? Right, so if we're very good at diagnosing problems, we can get to the medical model to kind of figure out what the organism is, but sometimes it's structural. Some of the things that we see when it relates to individuals' health isn't necessarily poor hand washing or just the fact that there's an issue with the water, but as we drill down, so everything we do, and this applies to our clinical practice as well, we want to get down to the cause of the causes. So when we think about some of the major health disparities that we see, HIV, coronary artery disease, asthma, and I apologize that it's not as clear up here on the screen, but with a social determinants of health lens or even a health equity lens, these things are really just the tip of the iceberg, right? So by the time someone gets to us and they have a generational history of high blood pressure, or they're now infected with HIV or another sexually transmitted infection, there are other things below the surface that are going on that we may not get as part of the patient history, or that we may not see as the part of treating a disease. Some of them would be cultural beliefs, poverty, genocide, racism. I have here in the center generalized apathy, because I feel with some conditions we get to a place where it's chronic, it's not going away, we aren't really sure what we can do about it, so we're focused our attention into another area because we want to do things, right? We want to make change, we want to make a difference. So how many people say, by show of hands, how many people say potato? And now you have to be honest, how many say potato? No potatoes. That's the first time that's happened. So if we're talking about something that we eat, whether we say potato or potato, it's still a potato, right? Or a potato if you say, but to me it's still a potato. But when we're talking about our health, language matters. Health linguistics matter. So when we use the term health disparity, that lets us know that there's a difference in health among individuals. That difference, however, does not account for the fact that it's an inequitable difference. It just lets us know that there's a difference. So there are disparate outcomes in preterm labor between African American women and Caucasian women. There's a difference, but it doesn't tell us anything else about that difference. When we start to get into the concepts of health inequity or health equity, this sort of adds the added label to say, okay, so not only is there a difference that's here, but as we drill down further, this is an unfair but also avoidable difference in health. So it's not that it's unfair and there's nothing that we can do about it. There are distinct things that we can try to do to improve them. And the concept of health equity and looking at health inequities is grounded in principles of human rights and distributive justice. Because again, when we take this lens, when we have this framework, we're saying these things are different, but not only are they different, it is not fair that they're different, and because we can avoid them, we need to do something about it. Am I in your way? I feel like I'm, okay. And Whitehead has a really good article from 1992. At the end of the slides, I also have references if anybody was interested in reading some of these materials. But in the article, she talks about how health equity spans from the individual level all the way up to the provision and distribution of services. So it's not just a matter of saying you need to go to see your healthcare provider. What if the provider is 30 miles away? Or what if they're 5 minutes away, but the staff are so nasty you don't like to be there in the waiting room? You know, like these are all things that we need to consider in the work that we do. Some of the systems that we think of in interacting with people might be transportation. I think we do a very good job of sort of diagnosing the other, you know, like, oh, well, they can't get there by transportation or they need childcare. But there's some healthcare system factors. There are some things that we as nurses and our medical and social work and psychology colleagues are doing that are sort of contributing to the negative aspects of what we see. And when our patients encounter the system, they're interacting with multiple levels of that system, all the way down from the front-end staff who are maybe at reception or triage, up to the person in medical billing, you know, who lets them know that their bill is 90 days past due. The quality of care and the feasibility of accessing care, however, are poorest for the people who need it the most. So when we look at these differences in health, or we look at these health inequities, we see that it's not necessarily affluent populations or people who have access to, you know, health education or who have high health literacy that are being most affected by the challenges that we see. Oftentimes, people have tried to use access and utilization as a measure of how health can be improved or how well things are going. But again, some of the things that I just listed might be barriers to access or barriers to utilization that don't get accounted for in that picture. And once that happens, once you interact with a patient, once you interact with a client, depending on the setting that you're in, that shapes future occurrences not only for that individual, but also for you. So we're going to look at the case of Susie Skeptical and Dr. Bias. Now, if I have any physician colleagues in the room, doctor could be nurse practitioner with the DNP or a PhD prepared nurse, but just for the sake of it, Dr. Bias is a medical provider, a healthcare provider who's encountering her patient, Susie. Susie had to take 2 buses and a trolley to get to her appointment. She's running a little bit late because one of those modes of transportation got delayed, but she's trying to get there because she wants to honor her appointment. She gets there, she sees the expression on Dr. Bias's face, and instantly Susie is like, this isn't gonna go well for me. I'm already late. I kind of don't wanna be here, but I'm here. She has an attitude, so now I'm gonna have an attitude because she has an attitude with me. So Susie's first thought is, this lady can't do anything to help me. You know, she's already written me off. She's already shut me out in her mind, and so I might as well just take my things and go back home. Dr. Bias says, I wish she would just hurry up and get to the point. You know, why is she here? What is the problem? And I mean, she's late anyway. I have 10 other people that I need to see within the next hour. What's going on? And so in their minds, before they open their mouths, they're going back and forth through this exchange. Every time I come here, she's nasty to me. Every time I see her, she's late. And the past 5 people before her were late. And everyone who looks like her is late. You know, like all these things start running through both of their minds. But now what happened? They're gone, right? They have been totally covered and masked and are now invisible because of all the spoken and unspoken things that happen in this exchange between them. And one of the other important things that I want to note, our own biases cause this to happen. So even if someone doesn't say something negative, if we have a certain perception of hair color, skin color, height, weight, we're doing that in our minds, and the more we do that, the more that we are invisible to each other. So what could be some potential negative health implications from that exchange? She won't return. Complete breakdown of communication. She will not trust any doctors, exactly. One, what if Susie was pregnant? She went there because she wanted a pregnancy test. But now As an adolescent, she's like, well, I'm not going to tell this woman that I'm here for a pregnancy test because she's already giving me a certain type of vibe. And that has implications for her prenatal care. She might have unmet sexual health needs if this was not a planned pregnancy, unmet parenting needs. Now, if there were questions that she may have had or services that she might need to access, increased lack of trust in healthcare providers, as someone said, that one instance can shape future occurrences. And the sad thing about when this happens, even if her next provider is nice, Susie still is coming in with the lens from this experience. And there may have also been other health concerns that weren't mentioned. What if she had a headache that just hadn't gone away? And she's thinking it's because she's stressed. But when we have these types of exchanges and we lose each other in the process, there's so much that needs to happen that ends up not being discussed. As nurses, so for the nursing students who are, brand new out of high school, just starting in nursing careers, to our RNs, to all the way up to our PhDs and postdocs, as nurses, we have a moral imperative. It's not just something that's good to do for our practice and for our licensure, but morally, we need to consider the fact that all individuals should be afforded an opportunity to reach their full health potential. So if we see that groups of people or types of people or labels of individuals are now at a disadvantage when it comes to that, we have a charge to do something about it. And not only do we have the knowledge, but we have the critical thinking skills and the visionary leadership, and the ideas to be the change that we want to see. So now we're going to shift over, and what will be absolutely hysterical is for those of you who have seen my son, when you see him, just take the hair off, and it's him. Was I about 4 in this picture, Mom? I was 4 in this picture. He'll be 3 in December. But I grew up in Brooklyn, New York. Yes, I know I have lost my accent along the ways of my travel, but it will come out if I'm upset or sleepy. It does come back out. But from the time that I was young, I knew I wanted to do something to change the world. Literally, like I am going to grow up and I'm going to do something and the world will be changed as a result of it. And I have an aunt who's a nurse, and so as I got to go to work with her, she lives out in California, and sort of seeing her in action and hearing her stories, I said, aha, that's how I'm going to do it. I'll be a nurse. Then as I started getting older and learning about salaries and money, and I said, those doctors make about 5 times more than the nurses that I hear. So I think I'm going to go to medical school. Had conversations, did a program at Georgetown for high school students to learn about medical school, talked to my mom about it, and all the advice that I was getting was before you make a decision, shadow people. Think about what you want to do and then go follow for the day someone who does that and see if you actually like it. So I said, okay, and I always knew I wanted to do some sort of neonatal intensive care too by that point. Went to a hospital, shadowed the neonatal natologists and the neonatal nurses that were on the unit. And this was, I guess, like 15 years ago now. And again, I love physicians, so I don't want to sound in my talk like I'm bashing physicians, because I'm not. And the catchphrase, some of my greatest friends are physicians, when you're like not trying to attack a particular group. But in my shadow experience, I was more drawn to what the nurses were doing. And it wasn't because the neonatologist didn't want to be more involved in care, but by the nature of what his schedule looked like, he didn't have as much time as the bedside nurse had to hold the infants and feed them and do teaching with the parents. So that's what solidified nursing for me and confirmed my passion for NICU nursing. From there, I went to Villanova for my undergrad, have always been very passionate about global issues and doing some international work, so I had an opportunity to travel while I was a student. If anyone is interested in learning foreign languages or doing study abroad as part of your nursing program, I would strongly encourage it. I lived in the Dominican Republic for 3 months, and those were the best 3 months of my life. Just learning about another healthcare system, engaging with people from a different country. But I've had an opportunity to work both locally and internationally, which really gives me a better picture. I think sometimes in the States, if we travel just for vacation, we miss the mark on what's going on in other places. And there's a lot that other countries are doing well. I feel like with our Western mentality, we say, oh, we have everything, we know everything, and so we'll go, traveling across the globe to fix all the social mores. And it's like, no, there's some things that we can learn. abroad as well to bring back here. And looking at how I sort of arrived to where I am with this issue, I started out, and I guess the faculty can get me for it later, but it's the truth. I hated, absolutely hated research and psych. I wish that I wasn't telling the truth, but I am. Absolutely hated it. And I say that to say, because today the seat that I sit in, I do research and psych. So the two of them came back together for me. And I always like to share that with students because in your coursework, you will undoubtedly come across classes where you say, I don't know why they're making me take it. Even my other one, community health, and now I practice in the community. You know, like, I don't need this to take care of the babies. You can keep your stats, you can keep your surveys, you can keep your, lockdown inpatient psychiatric ward. I don't need that to be a NICU nurse. But what I found out was no matter how much I tried to run from it, they both just kept following me. And I started out in the NICU at the Children's Hospital of Philadelphia. And as I was taking care of, my neonates and my preemies, I saw so many adolescent girls coming in to see their children in the NICU. And it wasn't just that she was 15 and coming in to see her baby. Sometimes she had a 2-year-old and a 4-year-old coming with her, meaning that she was 10 or 11 when she had her first child. And that sort of piqued my interest in the psychology of sex, what's going on, and people can make their own decisions. I won't impose, my own beliefs on when people should have sex and everything else, but what's going on that at 10 and 11 and 13 and 14, that they are interested in sex, and then not only interested in sex, but having unprotected sex. And from that, I knew that one way to get that experience would be to do a master's in psychiatric mental health advanced practice nursing. I did the clinical nurse specialist program at Penn. And once I got there, again, research and psych followed me again. The young women that were on my caseload, the ones who were dealing with depression, anxiety, ADHD, were talking to me more about boyfriends and wanting to be pregnant and being sexually active than the girls who weren't, because some were coming to see me because they had gotten into a fight with their parents or they just wanted to pass to get out of the classroom, but those who were more severely impacted or influenced by a mental illness, anecdotally, it appeared that they had more sexual risk behaviors that they were engaging in. So I started thinking, well, again, remember, I'm going to change the world from 4. I'm changing the world. So if I'm changing the world, I have to be able to do something about this. I need to put together some sort of program. Maybe they can come and see me every week. So I start talking to my friends about it. And they're like, Bridgette, who's going to pay you to do that? Who will pay you to put together a program? Or if you do put it together, how will you know that it worked? How will you roll it out? So those were questions that I couldn't answer because I didn't have training in program implementation or the research statistics that you need to evaluate something. That, on top of the fact that Penn at that time was fully funding their doctoral students, I said, PhD sounds good to me. If you'll pay for it and it falls in line with what I need for my career, then I'm sold. This expression of sheer joy, for those who can't see it, my hands are up in the air and I have a smile that probably goes behind my ears on both sides, just to be done. Because those who have earned doctorates, it is a laborious process. Those who are in programs currently, don't give up, hold on, you'll make it through. But what that did, it gave me very rigorous and intensive training in social and behavioral sciences, meaning that now I can learn how to design these programs. I know how to partner with the communities that I want to work with to make sure that it'll be effective and sustainable for them. And I can evaluate it to say how it worked, why it worked, and whether it didn't. And now, because I have these letters after my name, I can submit a grant to someone and maybe they'll fund me to do the work that I'm so passionate about doing. I finished the pre-doc and perfectly timed it so that my son arrived after my dissertation, so I was done with my pre-doc and in my postdoctoral studies when he was born. And that gave me an opportunity to look at independent research. Prior to that, I had my dissertation committee, my faculty mentors, but this sort of gave me a time to stand on my own and say, okay, Bridgette, what are you passionate about? How do you generate and answer the questions that you're interested in? And then again, write for funding so that you can not only do the work that you want to do, but make sure that resources are getting back into the community that you think needs it. And so now, in a position as an independent scientist, I have an area of research that's a high priority area. It has a significant impact in the communities that I'm working in and serving, and I've expanded my network of collaborators. So it's transdisciplinary, where I have sociologists and physicians, working on getting a few engineers, just because we all think differently, so that diversity of thought is so important as we're moving forward. As Dr. Specht was saying earlier, one of the arms looks at individual factors. So this really has a community-based participatory research frame and feel to it. How many people, by show of hands, have heard of CBPR? So basically, in CBPR, it's not just you as the researcher going into an environment and saying, I think this is what you need to change. Or I read some statistics and it looks like you're struggling in this area. You're really working with them, one, to see if it's a problem, because what if I think that the water supply is a problem in an area and they don't, they won't be as likely to invest in it because it's not an issue for them. So CBPR is one of the strategies that we can use to make sure we have those partnerships. For the social and structural level, looking at historical analysis, so going back through, if you're working in a community, knowing the history of that community, who settled it, how did it come to get the name that it has, how did additional people come in, and the flavor of the neighborhood change. With community mobilization, looking at our key stakeholders, and a key stakeholder is any individual that you can partner with for the program that you want to do, but who's invested in seeing change. And that can be anyone from an administrator or an expert that lives, resides, or works in the area that you're thinking about. And then for the intervention development, all the fancy research stuff with the randomized controlled trials, looking at translational science, but just ways so that you can develop programs and then get them out there. I think for a while we had it in research where people would do all this wonderful work and then it sat on a shelf. It sat in a book, it sat in some journal articles, but now they're really looking at the bench to bedside model to make sure it's coming out. So that I don't lose you, because I know it's after 5:30, you've had class, you've worked all day, and you're here. Why should we engage the community in what we do? Say it again. So they have ownership? So they have ownership, yes. Design? Yes. So they have ownership in the design. To increase sustainability, yes.
I was going to say, you're a member, if you're working in the community that you're researching, you're a member of the community too. So as the community flourishes, you'll have more benefits for you too. More people are working, more people are healthy, and it's like a advantage for you living there as well as other family.
Right, so the mutual benefit, if you are already in this community, as you help improve things there, you can experience some of the benefits from that as well. Exactly. So then it should be really easy, right? We have our concerns as the healthcare community. They have their concerns as the general population. And so it should just work. And you're laughing, so that means you know that it doesn't just work, right? And it's not just simple math. But what happens is we go through these questions and we say, well, do we need them? And I have them in quotation marks because who are they anyway? We talk about the community. That could mean so many different things. A physical space, a social space, an online space. In our technology era that we're in now, people can be in different countries and form their own community around a particular issue. But we say things like, we're the experts. We don't need them. We have our training, we know what we want to do, or we've experienced it before. We see all of the problems. I've read the statistics. I know what's going on. I see it, so I'm going to come in and fix it. We don't need them. We have it on our own. We've done similar things before, so we know it will work now. We were in Los Angeles, and we did this really wonderful program, and so now at St. Luke's, of course it's going to work, because it's a hospital. And we know what's best, right? And I have here no parking. If at any point in your clinical practice, your research work, your coursework, if these thoughts start running through your mind, you tell them that they can't stay there. I want you to stare at this visual and memorize it. No parking on any of these thoughts, because one, it discredits the value of the place that you're thinking about working with, right? So let's say that you go and you're working on a nursing unit, and you've come from California and you did some really wonderful work there, and you want to transplant it here at St. Luke's, and so these are the thoughts you have, and you don't involve your nursing colleagues, and you just kind of go and you run for it. Well, they're going to look at you like, well, you never asked us what we thought, or we tried what you're proposing to do and it failed, so why would we waste our resources again? But if we build it, they'll come, right? If we put it together, if we get the money, we put it together, we have a ribbon cutting ceremony, we do all the bells and whistles, won't they participate in it? And if there are any English majors in the room, I apologize in advance because I have some double negatives going on and it's probably not proper English, but it was what flowed in my mind as I was thinking about it. If what we build is not relevant or appropriate, so if you develop a program, if you want to implement a course, if you think of a way of engaging students in a different way, if it doesn't fit their lived experience, if it doesn't fit the context in which they think and they live and they work, they're not necessarily going to participate or be a part of it. Not if a representative individual from that group was not with you when you put it together. Now again, we could pick up anything and do it, but let's take the example of the water supply. If you go to another country and you try to do something with the water there, but you don't have people on the ground that are working with you, there could be cultural concerns about your intentions for coming in to do that. Oh, they came and they put something in our water so that we can't have children. Or you never know what could go through people's minds, so you want to make sure that you're inclusive in what you do. Not long term if sustainability wasn't considered at the outset. And I love that the president said sustainable change. We don't even speak that way. We just talk about change. We've got to do something to make it better. We have to do something to see progress. But if we don't think about how it will last and how it will stay once we're gone, then we almost do a disservice to the time and the energy and the finances that have gone into putting it together. So I talked before about how the emphasis is on action. Why is action important, or active engagement?
Yes. If it's passive, then your community isn't involved. It's just laying something on top and the community is not taking part.
Exactly. If it is passive, the community is not involved. That's the equivalent of someone saying, I'm going to mentor you through your nursing program. Put my name down as your advisor. And then every time you try to get in contact with them, you don't hear from them. And then you graduate and they're like, oh, she was my advisee. And you're like, no, I wasn't, because you never helped me. It has to be a real active engagement process. Our lens. So again, we have to consider our own biases as we are able to afford college education, or we have other means to be here to receive college education, as we consider nursing as an option and not, doing something in auto mechanics, as we have all these different areas and ways that we think, that's going to shape our thoughts. And when we don't recognize that, it sort of clouds the strength and assets that may be on the ground already, because we can come in like, I am here today and I'm your nurse and this is how I'll take care of you. And I have a perfect example of this one. I was doing my clinical and I went in to see the patient and she had forks in her hair. And the resident came in with me and he says, oh, I'm going to order a psych consult because this woman she's gone. She has forks in her hair. I'm going to get psych to come in. And I said, well, did you ask her why they're in her hair? And he said, I don't care why she has forks in her hair. She has forks in her hair. I'm calling psych. So I'm like a little sassy one. So I said, okay, go ahead. You go call psych. I'm going to go and talk to her. I went in. She was curling her hair. She didn't have rollers. She was in the hospital. Her kids were coming to visit her. And so she wanted to look nice for when her children came. So she put the forks in her hair to curl her hair. And I said, she needs like a Nobel laureate or something for that, not a psych consult, because that was pretty ingenious. But when, again, the lens, so he may have been coming in saying, I'm here, this is the job I'm supposed to do, without really engaging. And I use that as an example, and I have to stop all these physician references, but we can do the same things ourselves. And I call the other one the great hope phenomenon, where we have the best intentions and we're so excited. And it's like, I know that you've been struggling, but guess what? I'm here. You know, like if I came here tonight, guess what? You guys have something you need to learn, and I'm going to give it to you, regardless of whether you laugh or you smile, you know, just coming in like the great savior. But we can't do that. We cannot do that, because we have to respect what people already bring to the table. We have to respect their core values and their beliefs. Even when we are a member, and I think a young lady on this side said it before, we have certain groups that we want to work with where we're a member, right? So if I want to do research with Black women, as a Black woman, I am a member of that cultural group. Or if on a nursing unit you decide that you want to try something new for patient care and you're in MICU, you're a part of that group. The minute that you step out to do research, or you step out to become a program designer or a program coordinator, you have now become an outsider because you've changed your position within that group. And it's very important to remember that. And it doesn't mean outsider that you can't work anymore, but just like think about the times, you know, and don't admit to it because I don't want your grades to suffer, but the times when, you know, the professor leaves the room and you're like, what was she talking about? She didn't even, you know what she was saying up there. But you put a distance between you and the population that you're working with. And you can overcome it and you can still work, but it's important to remember that you are now an outsider. The other side of that is you cannot assume that membership is going to give you direct access or some, you know, magical connection where people will just welcome you. So as I gave the example of if I were doing work with Black women, as a Black woman, I can't just go in and say, guess what? I have your best intentions at heart. I'm here to help you and I'm here to save you, and so let's go. And it's like, well, no, you are Dr. Brawner and you're in that ivory tower over at Penn, so it all adds levels of potential mistrust or questioning of what we're doing. Teach a man to fish and he'll never go hungry, right? So if we actively engage communities, once we leave with our resources and our manpower and the dollars that we've brought in, they need a way to keep it going on the ground. And if we came in and did everything, whether it's a nursing unit or, where is Mona Lisa? Or a playground, you know, if we come in and we try to do something and we don't involve them in that process, guess what? When we're gone, the program is gone. So we want to be mindful of that as we're working. So now we're going to just go through some strategies to actively engage communities, things that you want to think about as you're moving forward in your coursework for the nursing program or your research if you're on faculty. And how am I on time? Because I can. Okay. The first one is to maintain presence in socially meaningful places. So if you are interested in doing a program with Latino adolescents about dental caries, and all that they hear about you or all that they see of you is when it's time for you to come and present on what you need them to do, you don't look invested. You look like you're there to push your mission and to do the things that you want to do, whereas let's say that they have a parent-teacher association evening and it's open, you know, and you could go and be present at that. Or they ask nurses to come in and do hand washing with the kids as part of a separate program. You want to be in those places so that the more they see your face, they get it and they say, wow, like she really gets us. Or she's really here and wants to be a part of us. The same on a nursing unit. Let's say you work in MICU, but they want you to roll your model over to the NICU. Lunchrooms in those two settings are very different, so you might want to start hanging with some of your NICU colleagues. The next one, advocate to ensure the key stakeholders are at the table from the beginning. What do you think of when you see this picture? And for those who can't see it, it's like a circle shape with the chair in the center and then empty seats all around it. Nobody's there, right? So this would be one of those grants where it says, yeah, we're gonna put together a community advisory board, get 10 people on it, and we'll let them know what we're doing with our study. And then over the course of the study, the group never gets formed, or it gets formed and then they mail them newsletters, but never bring them in to talk about what's going on. So making sure that they're at the table, and that term at the table is so important, because it's not that you bring them and they're sort of on, like figuratively the outskirts of the room, where it's like, well, I want to bring you here, but don't talk. Because I'm just going to tell you what we're doing and what you need, and then you absorb it, you leave, and you get the rest of the community to buy in. We would be insulted if someone did that to us, but that's what we do when we don't actively engage the people that we're working with in the work that we do. Consider how equal partnerships are, and work to maintain power balance. And those quotations are they're there for a reason, right? Because equal, when we look at particularly, let's say, an academic partnership, so if Moravian were to partner with one of the local schools around an obesity initiative, there's already a power differential there, because you're a college, you have set resources in place, you have set intellectual property that's already in place, and so the school may feel that they're on a level below where you are. And so being cognizant of that coming in, you can try as much as possible to level the playing field, or sometimes I've seen investigators appoint one person from the academic side, one person from the community side, and they have joint power. Or for your school, your coursework, if you're working in groups and you know that somebody struggles with PowerPoint, or somebody isn't the best writer, making sure that you allow them to contribute in other ways, because what you learn by doing that will come out and help you in your practice. Fight for health equity so that all individuals can reach their full health potential. And that doesn't just mean fighting in the healthcare setting, right? So like making sure, we want to make sure that we're, culturally, we've come up with so many terms: competent, sensitive, tolerant, there's all the different catchphrases for it. But if we do that piece and we miss the social part, and we miss the political part, and we miss the economic part, it's almost like we haven't done anything at all. So we want to be cognizant and mindful of the full picture. Strive for visionary thinking, which is why I'm so, again, just honored to be here on behalf of Dr. Sipple. If we have a go with the grain mentality, then everything will always be as we see it today. And not that everyone in this room is going to be the person that's sort of like, driving the nail with the hammer on every issue, but if you see something, speak on it. And not just speak on it, but think, okay, this is where we are today, this is where we want to be tomorrow, but what does that mean for that person 20 years from now? Where will this be, after I'm dead and gone from this place? So always being forward thinking and visionary in the work that we do. Challenge intentions. If part of me is like, this is what I have to do to advance in my career, but I really want to make sure that I help the community. Those are two valid points, and with having both of those within you as the same person, there's only one of me, that's going to sometimes be at a tension, where what you need to do to get through your classes, what you need to do to make it through, your 12-hour shift might go against what's best for the patient or what's best for the community. And so you always want to make sure that you're thinking about that, and that it's in the back of your mind. And if something's not lining up, or your thoughts and your will are going above what might work best for them, that you get the tension in check, because it's just one of you. So you get yourself in check, and then make sure that you're moving forward in the best way for your patients. Listen to and incorporate their voices. How many people are married here? Good, so a lot of hands. If you ask your spouse to do something, and they're like, sure, yes, baby, oh, yes, it's done. And then you come back and you're looking, you're like, no, it's not done. Your honey-do list is still 10 items long and nothing is done. When you listen and you don't do, or you listen and you don't incorporate, you might as well have just closed your ears and not listened at all. And so if the settings that you're in, if they say, oh, well, we would be interested in sexual health education, but we don't want anything around condoms. You're not allowed to mention condoms here. And then you come wheeling in with like your anatomical models for the male and female anatomy and condom. You didn't listen and you didn't incorporate. And that can get you pushed back out of the door. And we actually, some of the work that I've done has been in the faith-based community. And so people have different levels when it comes to the faith community that they're willing to commit to HIV or working around other STIs. And some people weren't willing to accept the fact that there were certain churches or certain mosques that refused to have discussions about condoms. And so they violated, what they were told and tried to bring it in anyway, and that closed the door. And then guess what? For the next person who tries to come in, they'll say, well, no, because you're going to tell me one thing and then do something else when I turn my back. So some of the things that we must do: recognize the strengths and assets within the patients and communities that we seek to help and serve. We have to know that, okay, coming in, I'm not just going to take a deficits approach. I'm not just going to think about everything that's bad and that's wrong. What's going well? And how can we appeal to or target or bolster the things that are going well to see change? Acknowledge our own biases and preconceived notions. As I said before, it's tough because a lot of this stuff is so entrenched that we don't even get it. I shared an example with them earlier that I was teaching a human development course at Penn, and we were talking about obesity among different racial and ethnic groups. And I said, well, why do you think obesity rates are higher among African American and Latino populations? And the one girl, very eager, raises her hands and she says, well, I think it's because Black people would prefer to eat at McDonald's than KFC. And so I paused, and I kept my composure, and it's one of those where it's like, Bridgette, you better not respond, just keep your mouth closed, don't say anything. But what I did, I opened it up to the group and I said, well, what do you guys think about that? Does anyone agree or have a different opinion? And so if you were in the classroom, what would you have said in response to that? And please don't say you agree, because then I might have to come and find you. But what would you say? So that comment was made by one of your classmates, and then the professor opens it up for the class to discuss it. How would you respond? You're stereotyping. Why did they come to that conclusion? Yes, that was one of my responses, that, I do like it, but because it tastes good, not because I'm Black. But what was nice is we had students in the room who got it. And so they were saying things like, have you ever been to one of these neighborhoods? Like, they have to travel 45 minutes to get to a grocery store, or do you see produce trucks riding through these neighborhoods? Or how about the fact that, $8 for these vegetables or $4 to feed a family of 4? Maybe those are some of the things that are coming into play. So what warmed my heart was, one, I didn't have to respond because it may have gotten me out of my position, and two, that there were students in the room who saw the social level influences, right? Those structural influences. And there was even a student who was working with a faculty member on a research project where they mapped where these communities were and where supermarkets and fresh produce was, to show how far they had to go. But I tell that story not to make the student look bad, because she wasn't trying to be disrespectful. And that's the part I think that hurt me most. I was somewhat offended by what she said, but the fact that that was really what she believed, that was all she knew of people who were African American or people who were from other racial and ethnic groups. One, because of things that she was taught in her family. Two, I don't think the media does us any justice with some of the commercials and things and shows that are on. But it was nice because it was a teachable moment, and towards the end, her eyes were just welling up with tears, and she was apologizing profusely because she hadn't gotten it before. But if we don't have those types of conversations, we never know that that's a bias, because to her it wasn't a bias. It was a fact for her. That was her truth. But because we could, in a safe space, have that conversation without anyone flying off the handle, without anyone being disrespectful, she now can go out and talk about that to other people who may think like her. Act locally, but think globally. And even acting globally as well, remembering the importance of that. So things that you do right here as part of your nursing coursework, as part of your faculty positions, have implications not only for here in Bethlehem, but as we have all this technology and ability to travel, we can learn from each other. I have a colleague who is looking at faith-based initiatives for HIV prevention. And they've done some really amazing work in Ghana and gotten their rates down by partnering with faith-based communities. So she wrote a grant to say, hey, instead of us doing all of this, like the US is coming, you know, here we come, we're gonna save you, they're doing it well. So I wanna go there, figure out what it is that they're doing, and see what we can bring back to have an impact in my community. So always remembering that it goes both ways. Even in the hospital setting, you know, if you're having a hard time with a particular patient case, you can sit down on clinicals or, you know, on your rotation and say, you know what, I've seen that a lot of people are coming in and like their blood pressure just isn't coming down, you know, and then when I talk to them about what they're eating, it's high in salt, it's high in fat, what do you think is going on? And then that patient might be able to give you some insight into what you're seeing. And then remember that we do not know everything. I don't care how many letters you get after your name. And it's like, I have, there's a gentleman that I know where he's done probably 7 degree programs now and puts them all on his email signature. And I'm like, just put PhD and like, just stop there. But none of the letters matter because we're not the expert in what we're trying to do. Unless it's something related to my body, you know, and the things that are a part of me, I'm not an expert in that. And so it doesn't matter how many years of training I have or where I currently practice or, you know, who my employer is, I am not the expert on someone else's issue. So how then will thinking this way benefit the public? If we remember basically, you know, our place and our position, if we respect who they are and what they bring to the table, if we consider sustainability from the outset, how do you think that'll benefit others?
Like you did in the example of the second patient and the live doctor will help bring awareness to see issues.
Right, so it'll help prevent bias and bring clarity so that you can see issues. I want someone from the nosebleed section to yell down so I can make sure you're not sleeping up there. They're thinking. Say it again. Oh, now you're on the spot. You thought that you could get the cheap seats in the back and not have to participate, right? I'll help you. So if we look at health equity promotion through active community engagement, it has several sustainable implications. One, for our community members. They have now, and again, community is your nursing practice, a physical community, you know, outside of a healthcare setting, students, whatever the setting is that you're working in. But they are now engaged in the process. You value their ideas and opinions. You ask them a question and incorporate it. A really good example of this, I have a youth community advisory board for my work. One of my studies is doing HIV prevention for Black adolescents with mental illnesses. So I have a cab of 10 youth who are between the ages of 14 and 17 who are in the demographic that I'm studying. One, because I'm obviously not between the ages of 14 and 17. And two, my lived experience is very different from them. They've grown up in Philadelphia. I grew up in New York. You know, so I need their insight because they're the experts for their group. For clinicians, we know that, and especially here with Dr. Sipple, evidence-based practice is what drives what we do. So it's not that someone comes up with a good idea and says, oh, you know what, I think today that when we change our central line dressings, we should like do a handstand first, then get the gauze. Like it doesn't work that way. We need to have science backing up the things that we're doing. Policymakers, back to the water example, if we just keep fixing the things on the surface, and there's policies and structures in place underneath that shape what we see, the issues will keep coming back. So by having this new lens that we've talked about tonight, it also has policy implications. And then administrators, the people who are responsible for rolling out what these new laws and procedures and policies are. Educators, as we're teaching the next generation of nurses, as we're teaching our patients, as we're teaching the teachers, you know, all of this will trickle its way up the chain. And then for research as well. One of the things that I'm so happy finally clicked for me is that research is actually advocacy. So when I was in the classroom taking that course, I missed that. I mean, and I wish I could convey how much I strongly disliked it, because I did well on my exams, I did well on my work, but I was frustrated with my professor because I'm like, why, tell me why I need this. And she couldn't even really articulate that to me. She was like, well, one, you need it for course credit to graduate because it's required in your program. And, you know, she's like, but it's going to drive your practice, it'll do this, but it still wasn't clicking for me. But now in a position to ask the questions that I'm passionate about and then do something and see that it worked, I can see that that's a better way than me just standing up saying, hey, I have a really great idea, I saw this, I think this could work, but if I have numbers behind it, then it sort of gives validity and vouches for what I'm saying. Partnerships are also very important. So nothing that I have done has been in a vacuum. It hasn't just been at Penn or at Villanova. I have partners pretty much across the country. And then you see here I have our St. Luke's School of Nursing at Moravian College. One of the funny things, a tie here, I actually came to visit when the nursing program first started and was accepting their entering class, and interviewed and spoke with Dr. Sipple. So to have been invited back for this was nice for me to see it come full circle. But we have to remember that even in patient care, if you try to do everything in a silo and you're not making connections with other people, or one of the things we learn, you know, be nice to pharmacy and be nice to your unit clerks. Because when you need what you need, if you've been nasty or if you've been walking around, you know, Miss RN, BSN RN, then they might not be as inclined to help you. So partnerships at all levels are very important. So my next steps, I think part of what we all have to do, a lot of what we talked about tonight has sounded very big, right? So it's like, oh, there's structure, there's social, you know, there's individuals, there's so much that has to be done, which is true. But I'm guessing we have a couple of hundred people in here. If we each took a piece of that pie, if we each took something and owned it and became the master of whatever that thing was, by the time you add it all together, you've really made a difference. And so sometimes I get overwhelmed, especially when thinking about health inequities, because it's like, well, you know, racism, what am I going to do about that? Or genocide in another country, how can I combat that? But if I take my piece, it'll play a portion, you know, where it needs to do something and can then be translated somewhere else. So for me, one of the next things that I'll be getting into around community mobilization, I had a pilot study to look at 4 Philadelphia communities and begin to tease out some of those structural and social factors that contribute to HIV rates among Black Philadelphians. It went very successful, and we saw what a lot of us in this room know already: poverty, hyperincarceration of Black men, geographically and socially constrained sexual networks. That all came into play in the 4 neighborhoods across them. So I'll be writing a grant, it's due in January, to look at now a citywide analysis for the city of Philadelphia, so that we can kind of see what are sort of these HIV breeding grounds, and then what can we do to mediate what's happening, or what can we do to get in the middle between the risks that we see, or, you know, the environmental factors, and then someone acquiring HIV. And another one that I'm very excited about, I currently have a grant from the CDC, as I was saying, to design the program for Black adolescents with mental illnesses. And this, I will say, keeps me young. You know, I'm 31 years old, and I thought that was young. But then when I get in the room with my 14 to 17-year-olds, I'm old. And so, you know, I'm like, oh, we should do a Facebook page for the project, and everyone could do this. And she's like, Facebook, that's only for old people. And so I said, well, you can spit my old pizza out of your mouth. Because I do, and we have a very wonderful relationship where we can like joke and banter with each other. But I said, Facebook is old? She said, yeah, nobody's on Facebook, everybody's on Twitter. And I said, well, I don't have a Twitter account. And she goes, exactly. And I'm like, okay. But that even with them, they're high school students. You know, technically to most adults, they're kids. But guess what? To me, they're experts, because they know things about their demographic that I don't know. And so we have a Twitter account now. We still have a Facebook page that people are going on. And we're in the fun part of putting the intervention together. So we're waiting for our IRB approval to do some focus groups and some surveys with boys and girls in that demographic to get at what the exact behaviors are. But they're helping us come up with like fun strategies to teach the material that we know we need to cover. So they suggested a bingo, where anybody who has heard one of the things, you go up and you say, have you heard about this? And the person has to describe it. Or I'm trying to think of another, Family Feud. Like there were just different strategies that they came up with that it was so helpful to have them on our team than just us sitting in our office putting it together. So in summary, research drives evidence-based practice in all settings, whether it's a school, a hospital, a geographic community, a nursing, educational environment. Research can really help to change and transform the things that you want to see. Data can then be used for advocacy on multiple levels. So with my work with the R21 that I'm writing for the citywide analysis, that will have implications for the distribution of resources in Philadelphia, what communities might need a new agency opened, or where should research dollars be allocated to make sure that people have access to the services they need. Active community engagement is key to population health because we can dispense all the medicines we want. We can do all the blood pressures, we can take all the temperatures. But again, if we're not talking to our patients, we're not working with our clients and our communities, we'll miss the mark. And sustainable change is possible, and in my opinion, needs to be our benchmark for program success. So let's say in my work, if I can show that I can improve condom use for 3 months, great, that might get me another grant, but then what happens in month 6 when they go right back to what they were doing before my intervention? So we need to consider that from the outset to make sure that whatever we do will last. So right now, everyone in this room, you're in a position where this is the road you're traveling. The world is your oyster. The road is wide open ahead of you for whatever it is that you want to do. But the choice that you make today, whatever you decide when you leave here this evening, whatever you write for your next paper or do on your next exam, that will shape how the world is going to be tomorrow. So when we begin to live our lives that way and think that way, just as we go about our day-to-day activities, then we have more of a global and a visionary mindset, and we can make sure that what we're doing is going to last. And these are the references that I mentioned, which I will give Dr. Sipple a copy of the PowerPoint so you can have that. Thank you. And we're going to do questions. Right?
Yes.
Okay.
Any questions from our audience, particularly from our students?
Yeah. And don't be shy. It can be any questions. How did I know that I wanted to, go from my bachelor's to my master's, or how much time did it take me? Whatever you want to ask, you can ask. Yes? How much time did it take you? Smart girl, you're a smart one. So I was in my bachelor's program from 99 to 03, finished in 03, and then had a year that I worked without being in school. And then September of 04, I went back for my master's, did an accelerated program, finished that August of 05, and then started the doctoral program September of 05. And that's what my face did too when I sat in my first class, September of 2005, because I only had about 2 weeks between the programs. And I think there are gains and losses to the decision I made. For me, I was sharing earlier, that worked for me because the money that I was presented with made it not too appealing to go back to school, in all honesty. At 21, I finished when I was 21. My salary was $51,000, and then I also had a shift differential because I worked evenings. So I was making about $56,000 a year at 21, and was feeling myself. I thought I was like a big girl and was doing great things. And so going back to school, the master's made sense because I said, I had gotten offered a position. It was like $115 an hour. to do therapy, and there would have been a differential on that as well. But then the PhD, they said, yes, we would love to have you. We'll do this, we'll do that. And I said, well, what's the stipend? Oh, it's $17,500 a semester? No, for the year. You know, so there were some sacrifices and adjustments that I had to make along the way, but altogether, from the moment I graduated from Villanova to completing my PhD was 6 years. Yeah. Yeah. And that worked well for me because now I'm in a position where I have more time on the back end to do the work that I'm really passionate about. But whenever I tell that story, I always give the caveat, it is never too late to do it. Our model in nursing has changed, where before, people were encouraged to practice longer before going back, either for a master's or for a PhD. And so if you were in that generation, or if things have happened and you just weren't able to do it, it's still not too late, because the training that you get in a doctoral program really does shape the questions that you ask and the way that you're able to answer them. But I would say if there are students in this room who are thinking about it and something in this talk made you consider a PhD, then look into it. And sooner rather than later, because again, once you start working and life happens and kids happen, you know, it doesn't make it any easier to do it later. Yes?
You said about like maintaining presence so people know that you're there and that you're present, but how do you maintain that when the workload increases and kind of start backing away? Like what do you say? How do you say something that you want to see growth, but you can't give it everything you gave?
Very good question. She said, how do you maintain presence when your workload increases or other demands could pull on you that then take you away from physically being there? And that's a very real question, because it happens. Even me now, in my position as a faculty member and a PI on this grant, I'm not able to be at every focus group. I'm not able to sit in the waiting room, you know, for our mental health providers, but I make sure that someone on my team is. And so whether it's other students that you're working with, other faculty members, other nurses, making sure that someone who represents your group is able to be there in a meaningful way. And then if the time comes, and sometimes it does happen where no one can be there, being transparent about that. So having the conversation at the beginning, like, look, we're invested, we're here, but sometimes these other demands might make it where this week or this month we can't get there. You know, and letting them know in advance so that it doesn't just look like, oh, we're coming to our 2-hour, 21-minute mark with my son. But, you know, when you have, it's the dialogue, it's the respect of time, because the same is for us. If someone says, sure, you know, I'll be at your office at 1 o'clock, and they schedule 4 times and never show up, or they're 45 minutes late, you know, it just sets a tone. So we have to be respectful of our community partners as well.
Yeah, you seem so accomplished now at such a young age. Where would you like to be 5 years from now?
Oh, that is a wonderful question. She said, I seem so accomplished at such a young age. Where do I want to be 5 years from now? That actually is a really good question. I think, one, I am so in love with what I do, despite the fact that I literally started out hating it, that I would still want to be in this line. Continuing to write grants to have the money that I need to do the work that I want to do. The goal for the HIV prevention grant, I've been working with Philadelphia's Department of Behavioral Health, and the director is very committed and passionate to this topic as well. So he said, I'll tell you what, if you get this funding, you do your study and it works, I personally will work with you to make sure that it gets implemented throughout our entire system. You know, so again, that's those community partnerships, being present at the table. So 5 years from now, I would like to be doing an implementation grant to say, okay, we found this intervention, it was effective, and this is how you can roll it out, you know, in a citywide program, and then take it and launch it up from there. Yeah. Yes.
After achieving your doctorate in your program, do you see yourself continuing anywhere else in education under other degrees? Or?
It's funny that you asked that. So I think I am a glutton for punishment. because I did the PhD, then I did 3 years of postdoctoral training, and the question was, do I see myself doing any other degree programs? I'm actually currently a full-time seminary student. Don't ask where I find the time or when I sleep, but I'm working on a Master of Divinity at Palmer Theological Seminary. Yeah, so. Oh, you're clapping, baby. I've just accepted the fact that I'm one of those lifelong learner people. And, as much as I tried to fight it each step of the way, something else came where I felt that I wanted to learn or grow. And this one for me is for my own personal, and spiritual growth and development. So I'm enjoying it. Yeah. Thank you. I thought I saw. Yes.
Any suggestions for the mom and your work balance that you have?
Suggestions for being a mom and my work balance? One, I have an awesome son. So, and mom, yes, of course the mom. But he is almost an anomaly because the times when things really get tough, he can kind of, and we were talking about it before, I know we're not supposed to do like the Nick Jr. parenting thing, but I can put on Nick Jr. and he'll sort of veg out for like up to an hour. But that, and I shared earlier, my postdoc gave me time to figure out what my line was. And so, even with my husband, bringing home work in the evenings, working on the weekends, staying up until 2 a.m., there's just things that you really can't do when you have a family or shouldn't do too much of. So I had to start shifting how my time was spent during the day when I was in the office. I couldn't afford the hour-long crash my office vent sessions or standing at the water cooler for 20 minutes. I had to work in my time that I was there. But then getting them taken care of in the evenings, and then sometimes staying up later by myself for things that I really had to work on. And I am the queen of travel. So for me, travel is the best way to hit the reset button. But I have my moments where it's like, no more commitments. I'm shutting down. I need my own personal time. I have to do this for my son. And it's nice that, I have the support of my mom and my cousin and my husband where things he's taken care of, so I don't have to worry about, I can't do this because I'll have to drag him. But it's definitely a challenge. And you do experience the mommy guilt. So there are times where it's like, oh, I'm working so hard and I want to spend more time with him. Or like this week, I'm here now and then I go to San Francisco to present Saturday through Tuesday. So I'll be away again. So a lot of that does come up, but you find your line in the sand and then don't cross it for anyone. And I remember when I was doing my faculty appointment process for Penn, and I was saying, there will be some things that I can't do because I have a small family and da-da-da-da. And they said, well, you never say no to the dean. And I was like, well, I could see that you wouldn't, but I might have to. Like, no, you never say no. And I'm like, no, but I might have to. I want to make sure it's clear. But you find, what your limits are and what your balance is, and then you have to enforce it. Yes.
I appreciated so much the first slide about social determinants of health. I had the opportunity to hear a World Health Organization nurse scholar speak at a Sigma Theta Tau event, and she said that the number one social determinant to health is whether or not you live in a democracy. And I wanted to know what you thought about that, and would you ever in the future package what's happening successfully in Philadelphia and take it to Africa or countries where there is not democracy?
Yeah, and I would be a little leery to say that the democracy is sort of like the great equalizer, because even within a democracy, you've got all types of crazy things going on. So we could go into Kentucky, or I'm sure even some areas of Bethlehem where it wouldn't necessarily translate, or move over for certain communities. But I do definitely feel very passionate about the fact that if we find something that works, earlier before I was saying we can't just take it and automatically assume it will work somewhere else, but we can take it, find partners on the ground there and say, hey, I've seen in the literature or I've heard from a talk that you have an issue here around childhood, mortality from diarrhea. We did a really great program through St. Luke's Hospital. This is what we saw. What do you think about partnering together to see what we can do where you are? Or with my HIV work, looking at what's going on in sub-Saharan Africa, it's the canary in the coal mine concept. You can't have that many people in one area of the world becoming infected and dying without it eventually trickling to affect the rest of us. So the sooner that we can come up with some effective models, one of the things in this study, I'm planning to use mathematical modeling to sort of say what are the predictors of environments that then become breeding grounds for HIV risk. And once we find them, now we can preemptively go to neighborhoods that have this same recipe so that they don't look like the neighboring community. Yes. The nosebleed section has to do something. Come on. You sat through it, someone has to have a question. Yes.
What would be like your biggest like piece of advice for someone taking their DSN and going right into you said that you worked for a year between your undergrad and your so would you advise others to do that, or would you do you think it's more like personal?
Very good question. So she was saying, since I had the year between my bachelor's and my master's, is that something that I would advise for other people, or is it more personal? I think just like everything else with nursing, that everything is an individualized case. So for some people, they will need to go straight through because of timing, funding opportunities, degree programs that are available. Other people, if they are not already confident enough within themselves, an NP or a ClinSpec is a very autonomous position, so they might want some of that hands-on experience beforehand, to do it. So I think it comes down to how a person feels about their ability to practice, if they think they could pick those skills up along the way while they were doing their degree program. So I know other people who have gone straight through and they'll have like a per diem RN job on the side while they're doing the master's program. But I think it just comes out to how the person is, how they feel about their skills, how they've progressed through the bachelor's program, and then they can decide. Some people want to have at least 5 years to practice as a registered nurse before they go back for a master's program. But I think every person has to ask a couple of different questions of themselves and then decide from there. And it's not a cop-out answer, but that's really my take on it. Okay. Thank you. Oh, you want me to open it? Okay. I'm not going home. I'm actually going to stay at Moravian forever because I have been treated like a queen since I arrived. And this is recorded, so not that Penn doesn't treat me like a queen. This is just, it's a different type of queen here. Sorry. Okay. Oh, yeah? This is William. Thank you, honey. Okay. Okay. Oh. Okay. Oh, this is beautiful. Thank you. This is beautiful. Thank you so much. Our pleasure. Thank you. Thank you. I appreciate it. Okay.
That's our Moravian star, so now you can.
Yeah.
You can put this in your office.
Oh, yes, I will put it in my office to have the Moravian star. Thank you. Okay. All right. Yes.
This
Would you
time
like
I'd
to
like
say
to
hi,
thank our
William?
sponsors, Upsilon Alpha Chapter of Sigma Theta Tau International and the Pennsylvania Eastern Region of Nurse Leaders. I'd like to remind those of you who are nurses that if you'd like contact hours, they're available for you as you leave at the registration table. Of course, you have to fill out our program evaluation. And I'd like to invite all of you to join us in the Payne Gallery next door for some refreshments. And a sincere thank you once again to Dr. Brawner.
Thank you.